we'll get started, I know most of you were with us this morning. There's a few new faces, and welcome to those of you who joined us this afternoon for the second meeting today. For those of you that don't know me, I'm Maeghan Gilmore. I'm a Program Director for Health, Human Services, and Justice at NACO. And if we could, I know we have our name tags in front of us, but we don't know where everyone is from. So if we could just go around briefly and do this again for those of us that have joined us this afternoon, that'd be really helpful.
Paul Beddoe, Associate Legislative Director for Health Policy here at NACO.
I'm Leon Evans from Bexar County, Texas, which is San Antonio, and I'm a member of the National Association of County Behavioral Health Care Directors and the Vice Chair of NACO's Justice Committee. There's several of us vice chairs, but I get to participate.
Julia Kaiser with Burness Communications.
Mike DuBose, COCHS.
Flo Stein, North Carolina DMH, DDSAS, and NAZADAD, the National Association of State Alcohol and Drug Program Directors.
NAZADAD, that's a snazzy name. Donna Strugar-Fritsch, Health Management Associates.
I'm Pat Fleming, and I'm the Director of Salt Lake County Behavioral Health Services in Salt Lake City. I'm also President of NACO.
Nina Marshall with the National Council for Community Behavioral Health Care.
Anita Carville, Senior Associate at NACO.
Tom Joseph, Waterman Associates. I work with one of the NACO affiliates, the Human Services Administrators, as well as some individual counties and county associations.
Katie Best, Senior Policy Intern with NACBID.
Good morning. I'm Ed Harrison, President of the National Commission on Correctional Health Care.
Keith Barton, Medical Director of COCHS. Ben Butler, CIO of COCHS.
Pat Ryan, Executive Director of the California Mental Health Directors Association and President-elect of NACBID.
Nancy Torrey, COCHS.
Steve Rosenberg, COCHS.
I think we got everybody. Thank you. What we're passing around right now is an agenda for this afternoon, and then slides that Steve will take us through as he begins discussion in a few moments. But I think to start off, we'd like to just give you a little bit of a background. I know some of you heard that this morning, so if you need to, that's fine. We don't want to make you sit through it over and over again, but you can check email if you need to. But I think for the new people in the room, it might be a good idea to kind of give that background. So Paul and I will go through that a little bit, and then I'll explain what we hope to get out of today's meeting and our future meetings together, which we will do via webcast. So this will be our first and only in-person. But I'm going to have Paul kind of start out giving some background about the issue around pending disposition for NACO, and it's not new with ACA from our perspective. So.
That's right. For many years, NACO had the issue on its agenda to, as we have talked about it over the years, restore federal health benefits for pretrial inmates. And this issue has been in our sort of policy documents for many years, but in recent years has gained more urgency. And county officials had a number of different objections to the current policy that was their experience in most of the states, which was that otherwise eligible beneficiaries entered the jail and were stripped of their federal health benefits before they were adjudicated. So there was the feeling that this was, first of all, an injustice for the beneficiary because they were being stripped of something and violating the presumption of innocence. And there was also a public health policy argument that this interrupted continuity of care for otherwise sort of fragile individuals with complex conditions. And finally, the cost issue continued as the cost of providing health care in jails grew along with the cost of providing health care generally. Counties became increasingly concerned. And in the 110th Congress, we had legislation introduced by Congressman Alcee Hastings of Florida and Congressman Burgess of Texas to repeal the inmate exclusion in Medicaid and also similar provisions for CHIP and Medicare and SSDI. That legislation never really went too far, but we worked on it and we had it reintroduced in the 111th Congress. And at that time, with health reform being debated, we worked really hard to try to get the provisions of that legislation incorporated into the Affordable Care Act or the various bills that were moving around. Ultimately, that effort was not successful in totality, but when the Senate Help Committee was debating the provisions around the exchanges, we were able to get a little change to the chairman's mark. Previously, inmates were ineligible for qualified health plans, and we got the Senate committee through Senator Jeff Bingaman to incorporate a phrase, except for those pending disposition of charges, into the language about the qualified individual for coverage on the exchanges. So with the Senate bill becoming ultimately the law of the land through the final act there at the end of 2009, we find ourselves in a situation where we're looking at a Medicaid expansion that will capture what we believe to be most of our jail population, as well as a provision in the Affordable Care Act that provides coverage on the exchanges to the pretrial population, the pending disposition population. So as we work towards implementation, we've been trying to think through how we're going to implement those provisions on the ground.
Great, thanks. So to that end, how we kind of moved it through NACO, we are fortunate that we do have funding from Public Welfare Foundation to kind of help us look at the issue, develop some resources and materials that will help our members with this issue. We do have an internal working group that we have of county members on board, and we're working closely with the folks at COCHS on the issues. However, I think as we move forward, we're finding that there's a lot of questions and a lot more that we need to understand and help our counties with in terms of implementing this. So earlier today, we did have a meeting around eligibility and enrollment. We're now moving into, it's kind of a progressive party, I guess you could say, that we're talking about some of these issues and moving forward with that. So this is about the provider workforce area. And I think what we want to do with the working groups is, one, have you help us with your expertise and experience, answer some of these questions or bring up other questions that we may not even be thinking of, or help us kind of think through that so that we can in turn, when 2014 rolls around, prepare our members for this new look of things with coordination and what it means for jails and the community care on that. And I know Mike and Steve are going to talk a little bit about that moving forward. So I won't spend too much more time talking about that. The process of the group today, we are going to have future meetings via webcast. So this will be our first and only in-person. And February 22nd and 23rd are what the dates, but 23rd and 24th. Okay. We will get that via email to you after these meetings, along with participant lists and things like that. So you'll hear from me in a few days on follow-up, what that means to participate remotely. But we encourage discussion, and we hope that you have some things to share and some questions that you may even ask that we haven't thought about moving forward. At the end of the process, we certainly will put all of this together in a document outlining, issues that come up, discussion we had, questions we could answer, and some that we have remaining open. So with that, I'll turn it over to Steve and Mike. I don't know if Steve wants to talk a little bit about...
I'll do a little bit first.
Okay.
Great. So I just want to do a couple of thank yous. I want to thank you at NACO for hosting this. I want to thank Burness Communications for all of their support in this. I want to thank Paul and Spark Street Digital for making it possible for those of you watching this on the web, either now or later, to be able to see that. I want to also express my acknowledgement to Burness and Andy Schneider, who's now become a consultant to Burness and to COCHS in the development of this process, who was here this morning. Many of you may have known Andy, having been working on House Energy and Commerce literally for decades as a Medicaid advocate and as one of the national Medicaid experts, and we're fortunate to have his expertise as part of that process. As part of thinking through how, Kathy, you didn't get to introduce yourself, I'm sorry. Everyone, you missed the introduction.
Sorry. I'm Kathy Kumarker. I'm the VP for Medicaid Policy at the Association for Community Affiliated Plans. and former Medicaid director in New York, grappled with some of these issues.
Thanks, Kathy.
Thank you, Steve.
Oh, who else didn't introduce themselves? Oh, Marcia.
From GW.
Great, thanks. Thank you for catching me up on that, Nan. In the course of trying to think through what 2014 might look like, a part of what we've been thinking about is what is the current process through which an individual has their Medicaid suspended or terminated. And with some excellent background research from Julia Kaiser, Mike can now present to you what we've discovered and the questions that it raises, which are not insignificant in thinking about 2014. Mike?
So as we reach closer and closer to 2014, there are a series of questions that we're grappling with, and I think this is just the tip of the iceberg. We'll run through a couple slides here that talks about it. One question is, what happens to an individual with disability entitlements once they're incarcerated? I guess the question is, are they still eligible for SSI, SSDI, and or Medicaid? And then come 2014, what are the changes that will be in effect? Again, are they eligible for SSI and Medicaid? And we've been, as Steve indicated, working with NACO to try and hammer out some of these answers, and we're going to talk a little bit about that. Right now, the current process is that under the Personal Responsibility and Opportunity Act of 96, Social Security Administration is authorized to sign reporting contracts with correctional facilities to notify SSA of inmates coming into the jail, and SSA then discontinues the benefit, and above and beyond that, they notify Medicaid that they now have that person in the jail, which results in their Medicaid benefits being terminated as well. Essentially, this means that under the current setting, SSA and Medicaid are coupled. Now, going forward, come 2014, Medicaid becomes eligibility becomes a matter of income and not disability. So the big question at that point is, does SSA really have a basis for reporting that information to the state Medicaid office to result in folks' benefits being terminated? That's kind of where we are with that.
So just so you all understand the question we're raising. So right now, by and large, Don, I appreciate your comments this morning. It's not a 100% correlation, but by and large, people having their Medicaid terminated or suspended because they lose their status as an SSI or SSDI beneficiary. The question we're raising on a going forward basis, when eligibility is solely linked to income, what standing the Social Security Office would have to notify a state of an individual's incarceration status if that individual is not an SSI or SSDI individual. We don't know the answer to this, but we want to put this on the table as an important question, because our current hypothesis is that we would confront the same issues we confront now with termination or suspension going forward come 2014, i.e. that there would be a process through which SSA would pay a bounty to the sheriff would communicate that information to SSA, which would then communicate it to the state. The question we're raising, which is a public policy question, is does SSA have the authority to communicate the name of those individuals to the state when they're no longer SSI or SSDI beneficiaries? So we don't have an answer, but we want you all to understand that there's a significant possibility that we might determine that they do not have that authority, which would dramatically change the process we're discussing on termination or suspension. Are there questions on that, or is that self-evident to everyone? Yeah, Ed?
Not a question, but just to help understand the gravity of this particular issue, I attend the National Sheriff's Association meetings. There's one going on right now in D.C. People from SSI, they come and present and talk about the hundreds of millions of dollars. This is a huge incentive for the sheriffs to allow, and the jail folks to allow the feds in and count the people, get a correct ID on the folks, because often an alias is used in other things. And they take great pride in being able to cut off the benefits as quickly as possible.
Correct.
And they get paid.
And they get paid.
And they get paid.
And there's no doubt that that would continue. That's not the question. The question is, for the non-SSI and non-SSDI individual who is identified through that process, does SSA have the authority to transmit the name of that individual and their SSN over to the state? So for the people for whom the bounty is appropriately paid, whose SSI or SSDI benefits are terminated, there's no question as to the authority of SSA to notify the state that that individual is no longer receiving SSI or SSDI. The question is, what is the authority of the state, of the SSA, to notify the individual who does not receive SSI or SSDI? So that is the question on the table.
And because of that being the source of revenue, we don't anticipate that'll stop come 2014.
Right. So the bounty wouldn't stop. The question is, does the reporting for the non-SSI and non-SSDI keep going? Right. Do you understand that distinction that we're making? Great. Yeah, go ahead, Kathy.
I have a question, and I presume the question is being asked regardless of the issue of whether or not the individual is considered "quote unquote" Medicaid eligible because of the exclusion of providing
Correct.
it. So it's just being asked regardless of that issue.
That's correct, because the question currently is on the table. So if you think about how this plays out operationally, okay, if I am an individual who is eligible for Medicaid based on income, who has a chronic disease of some kind or another, and I'm incarcerated and picked up, and I happen to be unlucky enough to be in jail on the day that the bounty is paid, and I get reported to SSA, I'm out of jail a week later, but I suddenly find my benefits have been cut off, and I might be dialysis dependent, or might be dependent upon some other sort of important chronic disease treatment for which the health plan is going to deny me because they're going to say the state didn't pay them, so I'm not eligible for those services this month. And so the question becomes a much larger public policy question about what is the interface between all these systems come 2014.
I have. Oh, go ahead. And just because I wasn't actually familiar with this process at all, SSA reports regardless of whether do they only report the loss of SSI, SSDI, or do they look at anybody who's in that day who hasn't otherwise been reported, quote unquote?
No. They report the people that come in the door to SSA, and SSA then determines whether those people are on their records.
Right. And if
they are on their records, it goes further than SSA at that point.
Right. If you're not,
okay. If you're not on the record, so if you just happen to be in jail and you're not disabled, you're not on SSI, you're not on SSDI, nothing happens through this vehicle.
Well, I'm not 100% certain of that.
Not 100% certain.
Not, if you're not an SSI or SSDI person, we're not sure whether SSA still then dumps that information to state Medicaid.
Right.
But we do know that if you are either of the two, it goes to state Medicaid as well.
Right. Pat, you had a question?
Well, my question is probably tangential, but for people who are on Medicaid and SSI and SSDI, and they're jailed and their Medicaid eligibility terminates.
Coverage terminates.
Coverage terminates. Yeah, coverage terminates. If they're enrolled under the new system into the newly eligible expansion program, they're eligible, or the state's eligible for 100% FFP for those people, where at least in California, under disability,
all states 50%.
We're paying 50%.
Right.
So there's a disincentive on the part of the federal government to allow people to continue to be enrolled under the new expanded program when when they'll have to pay 100% of the FFP versus 50% under a disability program?
Let me answer your question globally without getting into the weeds on a very complicated issue that we've paid a lot of attention to. Okay. So what I would say globally is we do not yet know how the interface will be between the expansion population and the traditional Medicaid population. However, in the conversation that we've been having with state Medicaid agencies through our partner, the Center for Healthcare Strategies, we believe that states will set up one system for all Medicaid beneficiaries and sort out at a later date for whom they seek FMAP, if you understand what I'm saying. But that's yet to be determined. Yeah, Donna?
Rules, the proposed rule, there were 3 different scenarios proposed under which a state could figure out what they get in terms of old population, new population. And there were 3 different ways to do the math, you know, kind of doing it by hand, taking a sample and applying it, and so all of that's under consideration right now with comments having been made and all that.
Right.
So there's going to be one way, I mean, there's going to be an answer to that.
Right. But we don't know what that's going to be yet, to answer your question, and we don't know how that answer will impact the incentives. A related question to this that we're currently very involved in is there's a current provision of the notice of proposal rulemaking that says that if an individual applies for Medicaid based on disability, while their Medicaid application is being adjudicated, the exchange has to take that individual. So if you think about what happens right now, if
they're eligible for subsidized.
Right. So we think about what happens right now is if I apply for Medicaid based on disability, the state takes several months to process that application. During that time, I'm currently uninsured. So the intent of the statute was to make sure that I maintain insurance coverage during that time. Well, one of the things we've been looking at is how many Americans really are above 133% of poverty who apply for Medicaid based on disability, and the answer is it's not a very big pool. So these are all very weed-like questions that you're hitting on this that I'm going to defer, but I think it's important that they get raised. Okay? So if I could go on then to the next slides. We wanted to just bring that to your attention so that you all understand those issues. And now what I want to do is I want to just do some basic terminology to make sure that we're all understanding where we are. Nope. Great. So I think pretty much everybody in this room understands who's in jail. I think we can skip right through to this next to last slide, Nan, on the Massachusetts experience. And I want to just turn your attention to this data if you are not familiar with it. So the state of Massachusetts, which as most of you know, has almost universal insurance. I have an uninsurance rate of less than 3%. For my young adults who are substance-using adults in the state of Massachusetts, my uninsurance rate is running 22%, i.e., even in a state with almost universal eligibility, my enrollment challenge for the type of young people that we're likely to see in our nation's jails is vastly different than what we are seeing in terms of the overall Massachusetts experience. We have had substantial discussions this morning about jail as a locus of eligibility and enrollment, that for many of these young people, jail will be the opportunity in which to determine their eligibility and enroll them in the Medicaid program. We have a couple of counties in Massachusetts that are now experimenting with this through their sheriff because they're concerned about what they're seeing in the uninsurance rate of these individuals. So this is just a general factoid I want to make sure people understand. The next thing I would like people to take a look at is the experience of the state of Washington. Nan, can I have the bar graph?
The graph.
The state of Washington made a substantial investment in increasing substance abuse services for their low-income population. What they demonstrated, which is what you see on this slide, is that the provision of substance abuse services was able to bend the cost curve. That is, that instead of the cost of health care increasing for this population, that providing them with treatment services enable the cost of their health care to decrease, and it's an aggregate range of over 7% for a GA population and about 5% for a SSI-type state-only disability program on the left. What's important about this information when you couch it with the Massachusetts experience is that if we are going to bend the cost curve on a going forward basis, we're going to have to figure out how we incorporate these largely young men who are substance abusers into our healthcare system, and the important role of jails in making sure that we provide them with eligibility, with access to services, so that we can achieve this goal on bending the cost curve. So those are the two background pieces. Donna.
So this morning we didn't mention this, just popped into my head that for a year now, many of the people that you're talking about have been eligible for coverage on their parents' plans under the Affordable Care Act.
That's correct.
So I don't know how far jails have gotten in, if they have plans, if they know where their parents live, if the plan covers them, if they live out of area, if there's a network, blah, blah, blah. But
most of these folks are not, generally speaking, how do I want to say this politely? Most of them are not, generally speaking, children of parents who may have health insurance through work.
Well, I'm just saying.
Yes, that's correct. But I don't think
there's
that Mike
coverage
has seen,
available now for some of those people.
I don't think Mike Flo has seen this data particularly change since that's gone into effect.
Well, but that would depend on how aggressively a jail would pursue that. It takes a lot of work. I mean, has anybody looked at that?
No, I don't think anybody's looked at that.
Or how aggressively
I've got a nice elbow for you.
because we often get complaints from parents.
Right.
Son or daughter is not getting the care that they need. If the parent has insurance and information could be made available to the parent to aggressively go after this opportunity with the jail, there might be a good.
Well, what's happening also is, we hear is that the insurance plans are refusing to pay for that treatment if that person has been in jail, even if they're pre-adjudicated.
That's often the case, and you'd have to really push on that, but it's coverage that might be available to them at release. So it's just something else to think about.
I think it's a good question to ask Mike Flo when you talk to Mike about what his experience has been.
But
Yeah.
I think what Pat just said is a major issue, which is even if you happen to have insurance, getting access to substance abuse treatment, if you're privately insured, is not an easy thing to do.
Okay. With that, I want to just make sure that I want to try and move us along, that we all agree on certain terminology that's important for us to understand. And the first one is the distinction between eligibility versus coverage. So, come 2014, an individual who is eligible for Medicaid because their income is below 133% will maintain that eligibility at all times, whether or not they are incarcerated. The question will be whether they are covered during the time that they are incarcerated. This is an extremely important distinction for people to understand. The next thing I think Paul mentioned is that the PPACA defines a qualified individual, and a qualified individual includes those individuals who are pending disposition of charges, okay? The third thing to understand is that this, at the moment in PPACA, as Paul mentioned, came out of the Help Committee, so it is specific to the exchange and people who are purchasing health insurance through the exchange. However, one of the things we know about the people who are pending disposition is if I came into the jail as an exchange member above 133% of poverty, while I'm incarcerated pending disposition, I'm likely to lose my job. Most of these people do not get sick and vacation pay while they're in jail pending disposition. And I will immediately revert to being a Medicaid expansion population. That is, I will be under 133% of poverty. So one of the questions we've been raising with CMS is how does this harmonization work, i.e., what will be the status of those individuals who are pending disposition? Will Medicaid provide coverage for their services, and will and does CMS have the ability to harmonize the PPACA language on Medicaid with an exchange with Medicaid. On August 23rd, NACO coaches Sarah Rosenbaum from George Washington University and the National Health Law Program had a meeting with CMS in which we raised this question. CMS indicated that they believe they have the legal authority to harmonize the Medicaid coverage rules with the qualified person language for the pending disposition population. There were some comment periods in reference to Medicaid and the exchange, which substantial folks commented on. Thank you, Paul and NACO, for organizing an extensive commenting process for that. These issues are currently before CMS. So while we don't know exactly what will come down, what we do understand is the challenges that harmonization, if we don't have harmonization, the challenges of sorting all of this out is what I will say. And we know that it appears that CMS has the authority to do that. The next things I want to make sure we understand is Medicaid expansion is likely in almost every state to be delivered through a managed care context. That may be through a PCCM arrangement, but we will not see very many fee-for-service Medicaid expansion states. They'll either be through a health plan or through some sort of PCCM, but it's likely to be through some sort of process in which we determine, or there is a party that determines, who an eligible provider is to participate in the provider network.
That's true even for fee-for-service.
Right, yeah.
So we figure most states are going to put the expansion population into whatever arrangement they currently have,
Right.
which
Which
might
is-
be a blend of all of those things.
Right, might be a plan, it might be PCM.
But it won't, you shouldn't assume a plan.
Plans.
Or even plans.
Right.
There might be practices.
Right,
there
right.
might be fee-for-service
All-
docs.
Some sort of experimentation with provider networks. The key issue we want to get across for our discussion is that the important thing to understand, which is what we want to talk about for the next hour or so, is what will be the relationship, or what can be the relationship, between these provider networks and the provider workforce that currently exists in jails, and what will be the relationship, and what can be the relationship, between certain practices in reference to scope of service that currently exist in jails and the practice patterns for scope of service that would exist within a future Medicaid context. Does everyone understand those questions? And so the first question is a very simple one, was what is the current relationship between the existing jail workforce and provider networks, be that of a health plan, be that of a practice group, and I think that...
Is this Medicaid you're talking
Yeah.
about? So really, it's kind of, another way to frame it would be, is the jail workforce, or how could the jail workforce become eligible Medicaid providers? It's not...
Right, that's another way to frame it, okay? And I think that is a conundrum for us to think about, because...
That's the going forward question.
Right.
That's the current question.
That's the current question, okay?
There's
So
also the going forward question.
it's
because,
both.
Yeah.
It's both. I would say right now, with a few exceptions of large counties, San Francisco, Seattle, which provide the jail services through a publicly employed workforce and have public health plans in which these publicly employed workforce tend to be providers, that as a general rule, most jail health providers at this point are not credentialed or paneled by most state Medicaid programs within a managed care frame. I think that's a very safe statement for us to make currently. Okay? Huh?
I think there's some out there.
I said some. I said I think most. I am giving a couple
Most
of
are not.
examples.
Most are not, right.
Most are not. As a
Right.
general rule, most are not, I think. The challenge becomes, on a going forward basis, trying to think about what are the barriers and how could they be overcome in order to credential the jail workforce into the going forward Medicaid paradigm? That's the question we want to pose. Donna?
So just the jail workforce, by that you mean, I believe, or here's a question, do you mean the people, the providers who serve the inmates of jails? Because those aren't necessarily jail employees.
That's correct.
Okay, so it's the providers of inmate health services.
That's correct.
So then I think the question can be further parsed out by discipline, because nursing, primary care, mental health, there might be different answers to that question in one facility.
I would say that we're only
Especially
talking about
mental
advanced
health.
practice nursing, physicians, osteopaths, and mental health practitioners. I think that we're not going to talk about the RN and
And the
LVN.
division is quite possibly different between the physical health and the psychiatry in particular. Who
Correct.
may be
Well, but most
Medicaid
of it-
providers
right.
who are contracted.
Right, and a lot of the jail mental health providers are not psychiatrists.
Right.
So
Right.
I think what we're trying to talk about is what are the challenges in getting this population credentialed. And I want to just put together a few that have surfaced in some of the work that we've been doing. Go ahead, Pat.
Steve, so in states like Utah and I think California, where you have a carved out behavioral health plan, the counties, in our case, we're responsible, so it's carved out to us. So the
And in California.
psychiatric services are already under our responsibility, the county.
Right.
The physical health side is not, of course. So
For
I think
inmates? For jail inmates, you mean?
So
or for
no,
everything?
what Pat is saying is
general.
in
In
Utah
general.
and California, the counties control credentialing, is in my language, okay? So in Utah and California, the counties get to determine who the network providers
For
are.
behavioral
For
health.
behavioral, so that's low-hanging fruit, okay? If I go to another jurisdiction, okay, where behavioral health plans are very, very, very selective as to who they let into their panels, New Mexico, as an example, okay? Then the challenge becomes very great because these behavioral health plans are not interested in putting new providers on their panels, okay? And I think in general, their attitude is, we've met the practitioner to population ratio that the state required us to have in order to have a managed care contract, okay? Why should I now develop new provider agreements? I don't have any incentive to do that. So I think particularly in reference to behavioral health in carved out states where the contract has ratio criteria, I think it's going to be an extremely uphill, largely political, for I don't know who the advocate is, it's one of the things I want to talk about, in getting behavioral health providers credentialed within the workforce. So why don't we just spend a few minutes talking about that, Pat?
Is that going to change a little bit though, as integrated care moves forward?
For those states that move forward with integrated care, I think
Right.
we don't know yet what states will move forward with integrated care and what states will carve out. I think that's one of the questions.
It might be an angle to
Right.
work.
Yeah, and I think part of what the question I'm trying to put on the table is where does advocacy, so in where I have a carved out behavioral health program where I'm basing it on ratio, okay, in order for contract compliance, one of the questions I'm asking is, where does advocacy for this come from? Where are the pressure points? Yeah, Pat?
I'm just trying to think this through. I mean, in California, for behavioral health, it's an issue. There's a big difference between those people who can provide services under the rehab option and
Right.
where they can provide those services versus those who are in the fee-for-service system or the non-rehab
Right.
option. And the types of providers and the locations where they can actually provide and bill for those services.
Yeah.
So that's
Still a separate issue, right? Right.
So I'm just trying to think through, like, who is eligible under the current Medicaid system to provide and bill for alcohol and drug and mental health services outside of a rehab option type program or a carve out. Because those are the people that are going to have to provide the services whether they're jail employees or somebody else, to the jail population. What kinds of, under the Medicaid program, what types of credentials are required in order to provide those services?
Right, so one thing I just heard you get on, which I want to delineate my issues. So one is a really good question of what are the credentials, okay? What licensure / credentialing status are the plans likely to require, okay? The other one that I want to go back to is even if I have the appropriate licensure and credential requirements, what's the motivation of the plan to expand their panel, okay? So going back to the Mancuso data, okay, we just learned 10 minutes ago that there's good public policy reasons why we want to make sure that we have a provider workforce in place, but I have this sort of dissonance on this, Flo?
I think there's a difference in the incentives in a Medicaid plan versus a commercial plan. Like in a Medicaid plan, the state would tell its MCOs and their provider network, we want you, this is your population, you're responsible for it, we want you to cover it. And for instance, in our contract, we are already watching for cost shift to jail and prison, and because the state has to pay for the whole thing. And they don't want the shifts to go back and forth. They want the care to happen where it is most effective. And right now there's some momentum that if you get people exposed to treatment, that would be the most efficient, effective way to do it. So we require our MCOs to have a provider network that would include providers that could work with a jail. A jail could also, in our state, become a qualified provider.
Right.
The jail or people who provide services?
Well, people in the jail or their contractors, but they could become a provider.
Individual providers who work in the jail can be.
Well, the program could.
Both. Okay.
You license programs and individuals both, as I recall.
Right.
Isn't that correct? So, but I would say, Flo, that you are, because you combine your various roles in North Carolina, you're one of the more advanced states, which is why we always invite you to these meetings. You're one of the more advanced states in having thought this through. I think one of the questions I'm raising is, for the expansion population that's 100% federally funded, for states that generally don't particularly care about what goes on within their county jail systems, do I really think that states are going to turn to their behavioral MCOs and say, you need to make sure X, Y, Z, and Q are part of the provider panel in your contract? That's the question I'm putting forward.
Well, Steve, for okay, right now, 50 states, there's 22 of those states that the counties are in the game of providing behavioral health services. I think the thing we've been thinking about for all the rest of the counties, what is the common thing they do? They jail. So the counties, even in those states that don't deliver behavioral health services, still have an incentive here to get actively involved by their state county associations to advocate for making sure that those populations are covered and are getting services. In other words, are part of the health plan in their jails.
Right. So what I think I'm hearing you say, which is what I'm trying to say more politely, and you're saying more directly, is that there's probably some homework that we need to frame, particularly on the behavioral health side in terms of panel expansion. But I want to go back that we just made an assumption there, which Pat, I appreciated, mentioned before, which is the credential and qualification question. So we really have a couple of issues. Yeah, Leon. Yeah, you're going to have to tap me on the shoulder when I speak because I can't see behind me. Go ahead.
I have a concern that providers have enlightened self-interest.
Right.
And if I'm a provider who historically has managed care in a very low-rate environment, I probably don't feel too bad about somebody being in jail as opposed to me paying for some psychiatric stay, or being homeless, or So how do we align the public players here to all kind of have the same enlightened self-interest? I think that's going to be an issue because you could have some. Well, the public provider is going to, and we do right now. We have all the heavy care, all the very fragile, all the treatment-resistant, people that we're responsible for trying to make their lives better and get them into treatment. So, at some level, some discussion needs to happen about that.
Well, I heard you just add in my language, Leon, I heard you just a third ingredient to our mix, which is what's the relationship of subcapitation agreements in behavioral to particularly reaching out to this population. And I think that's another mix. I think, Flo, you're nodding your head because I think you're familiar with this issue. I think that's something else that we need to add to the mix as we consider this question. I want to go back just a little bit before we go on to the other areas of healthcare providers. I want to go back a little bit, Pat, to the issue that you raised about qualifications and credentials, because I think that's a really important one. And I think that the four letters that we don't like talking about in this arena are LCSW. And to what extent will plans require LCSW as a qualification threshold in terms of the credential of who they're willing to let in as a behavioral health provider? I don't know what you guys' experience with that has been. I know in some states that's been a credentialing threshold.
We're a little bit like North Carolina in that we have, our state does both professional licenses, individual licenses, and program license, and then our state law sets up a class of mental health practices, which is everything from psychiatrists, LCSWs, licensed professional counselors, and even licensed substance use counselors that don't even have a college degree.
So you're letting
so
LDACs can get into the managed
Yes.
care network in your state.
Yeah.
And in North Carolina. That's not true in California. So I think that this is, go ahead.
Because of the waiver, does it have to be a licensed provider of the healing arts?
Yeah. Right, yeah, okay.
And I'm thinking about this from a macro quality perspective, and I think that plans and perhaps probably even primary care case management programs may also have concerns about the impact of allowing these individuals into their provider networks if they don't have control over how the care is delivered and making sure they meet all the quality standards that they're trying to meet, and then how will that affect their NCQA or URAC standards and things on that order.
We're talking about that tomorrow afternoon, right?
Oh, well,
yeah, that's good, but it's an
didn't know
issue. It's an issue to put on the table.
Okay.
Right, because I think it's a real issue.
I think it's one for a provider network.
Yeah, and I think it's great. I think it's so you've added a fourth ingredient here, which is in addition to the subcapitation issue, this whole issue on quality and measurements. And how does that fit in, particularly where I have plans that are getting report cards from some agency or another. And I think when we go a little bit to talk about physicians, we're going to talk about this as well in just a few minutes. But before we leave behavioral, let me summarize where I think we're at, okay? One is this issue on credentialing, which, Pat, you've raised. Two is this issue on subcapitation. Three is this issue on quality, which, Kathy, you raised. And four, which is the one that I want to stress as my take-home message, is I don't particularly, when I scan the horizon, in most jurisdictions, I don't see a political constituency that is going to be heavily incentivized to encourage carve-out behavioral health plans to add to their provider workforce the kind of providers that currently exist within our jail system. And I want to put that forward front and center because I want to say if we recognize the extent of behavioral health challenges that offenders in jails have, then in our COCHS work, one of our frustrations is when we go through a jurisdiction and we look at this, I don't find a champion that I can turn to and I can say, who would I work with to make sure that these folks get on the panel? Donna?
Well, it seems that if a state Medicaid agency wishes to expand treatment for this population using federal matching funds, that the state Medicaid agency would take on the issue of making sure that there was a credentialing methodology that would allow those providers to be paid and matched.
Yes. And to partner with that in North Carolina, our whole community corrections system is county-based, county-operated, with county commissioners and judges and law enforcement officers sort of looking at gaps and planning, and they can decide how certain kinds of community corrections dollars can be used. So, and because they also operate the jails, they have a kind of built-in.
I would say you have champions in North Carolina, which is why you have a good system. Donna, I want to be a health plan that's going to have that debate with you. You gave me a contract. I meet my patient-to-provider ratios. It's my job to determine who I let into my network and who I don't let into my network. You hold me responsible for a report card that I have to meet certain measurements of. I wouldn't have bid on this contract if I knew that you were determining who was in my network. Thank you very much. Let me do my business that you pay me to do.
I disagree completely. It's a whole new line of business.
I'm just saying I think these are the discussions.
It's different than the networking. It's a different.
Yeah.
It's a different service.
I'm just saying when we've been having these discussions with the BHOs, this is the pushback
Well,
that
you
we've
wouldn't
been
have them
getting.
with the BHOs.
Huh?
You'd have them with the Medicaid
Medicaid
agency, who would then
Yeah.
say, we're looking for interested providers. BHOs not interested need not apply.
Right. Nina?
There's also the question of the timing of the contracts. I mean, if they're coming, like, they may have bid on one contract, but we're talking about 2014. There's still, it may not be in place exactly for 2014, but there's a timeline here we can consider.
So what I'm hearing you say is, and Paul and Megan, I want to make sure that you're in agreement with this, that the National Association of State Medicaid Directors would be a likely partner that we would want to make sure we include in this discussion going forward. That's what I'm hearing Don and Nina say. Do you guys agree with this?
Yep, and they were invited.
They were invited, so let's just make sure that we can't bring them to the table next time. I think particularly around this behavioral issue, which I think is a very challenging one, it will be an interesting set of conversations to have.
They're
pretty booked at the moment.
Right,
So-
that's right, they're pretty booked.
I
Go
think
ahead.
that there's a case to be made for engaging Medicaid directors in a comprehensive discussion of issues that relate to people who are incarcerated.
Yeah,
And
right.
some of it carries significant revenue opportunity, revenue enhancement, the FMAP thing,
Right.
you know, not even a third of the states are collecting that yet. This whole concept of new federal money being available for treating a population that's never been reachable before is another piece of that. I don't know if you can get them to come to little piecemeal discussions. I don't mean to be disrespectful, but it's just an extremely challenging time.
Right. And
So
they're
how you
only
would frame it
between
might-
now and 2014, they're only going to be more a challenge. And so, go ahead, Pat. What were you going to say?
Well, I was just going to say, I just want to clarify, in California, we don't have behavioral health managed care. We have mental health managed care. We don't, we have virtually no
There's no substance. There's no
abuse
Medicaid drug benefit.
Medicaid program other than methadone maintenance, to speak of. But
Which is true in
we've
many
never had,
places.
but we're going to have
Right.
have a benefit, and I don't think our state has even begun to think about. We've been trying to give them the business case for behavioral health and the cost curve and all that stuff. They're not there yet. They're not thinking about that yet because they've got bigger fish to fry. But I think they are going to come like pretty quickly when our behavioral health assessment is done from as part of our waiver to the realization that we have no structure for substance use right now.
And the big early savings are in the substance abuse part.
Yeah. So we have mental health parity right now. It should be being implemented right now, but it's not. And as of 2014, our state just kind of transferred Medi-Cal substance use and mental health responsibility wholly for Medicaid to the counties. And I think they're expecting that somehow the counties are going to assume the responsibility for all of this population, regardless of the fact that there's been no substance use program or benefit at all until now. So I think the readiness, forget the credentialing. I mean, there's no system right now anywhere, whether in the private sector or in the public sector, to deal with people's substance use issues. And all of a sudden, 2 years from now, we're supposed to have expanded to this new population, most of whom are probably going to have substance use problems. I think.
And it's interesting, Pat, for you to know, and I don't think you know this, as part of a realignment discussion that COCHS has been having with the governor's office, Toby has agreed to submit a waiver of statewidedness to create a drug Medi-Cal benefit in certain counties as part of realignment. And so we're in the beginning process. Did you know that was on the table? So this is just this is a realignment question, has nothing to do with the larger issues. But I think part of the argument we've been making is when you start talking about this offender and ex-offender population, because substance abuse is their number one characteristic, if we're asking counties to go ahead and provide them with services under realignment, are we willing to use Medicaid dollars to supplement the $109 so that counties can have greater resources to manage that population? And with a little pressure from the governor's office and the agency, Toby's initial answer was, I am willing to consider a waiver of statewidedness for selected counties. We should probably have an offline about that to just bring you up to date. But I'm just letting you know, I think that in some extent, using the CJ population, I think the moral of this story I'm trying to get to, Pat, is using the CJ population as the driving force is often a way to bring public policy attention to this, going back to the David Mancuso slides. Yeah.
So I would just suggest that in pushing the issue from that perspective, there's no reason to be locked into any arrangements that Medicaid currently has to provide services to the unincarcerated. This could be something brand new and different. And so don't think about plans and credentialing in the traditional way and behavioral health organizations. You shouldn't constrain yourself in thinking about it that way because it's entirely new and there might be a much more expedient way to get at it.
Well, I love that approach. I think, again, my question's going to be...
These people aren't going to be in... They're churning.
Right.
They're not going to be in
We're all
plans
there.
for
I think
any period of time.
Right.
It's a mess. And so maybe the better way to do it is to just start over. We have federal funds. We know what these people need. We have them in our building. How can we do this?
That's a great way to go. My question is going to be back to, given the state Medicaid directors have a lot on their plates, where does the championship for that perspective come from? And there's a lot of work to do between now and 2014 if that's the perspective I'm going to take. Pat?
Steve, just one little thing. You're talking about the types of providers that would be credentialed to provide services. I just got a chart the other day, and there are, it's either 24 or 44, I can't remember what number it is, states allow for peer professionals inside their Medicaid plans now.
Right.
So I mean, to me right there, it says that there's going to be a whole different level of credentialing that's going to have to happen, and which I think is great. And that then becomes, why would the health plans want to credential those people? Because first of all, they're already getting capitated plan. They're already getting paid for it. If they can provide that service and meet the criteria in terms of quality with a lower cost person, a staff member, they make money.
I want to go back to what Kathy said, and then I want to go to physicians in doing that, which is this magic thing called report cards. And with that, I want to talk a little bit about the issue of physician workforce. I want to just switch out of behavioral if I can. You want to say one more thing on behavioral?
Not behavioral. It's really in general. The way that many of the states that we've worked with, the prison systems have set up claiming federal matching funds, is to take those folks who are incarcerated and treat them as fee-for-service and forget about the plans because they're not in a plan and they're not going to be in a plan until they're out.
Right.
And so maybe that's a model for thinking about all of this, the way services are delivered to people who are in jails and how Medicaid or even an exchange-based qualified health plan would pay for those services.
I think the challenge is in prison I have a stable population. In jails I have an incredible churn.
But while they're in jail, they're not in a plan.
But remember, 50% of people are in jail for less than 72 hours. And
they're not going to get a lot of substance use treatment in that 72 hours.
Well, that's a really interesting question because the number one issue that comes up in those 72 hours is detox. Right. And so you do get a lot.
But that too is you could provide detox outside of a plan. in the
just
building.
I'm
so.
framing the complexity of the issue. So, for example, in New Mexico, where we actually, Dr. Barton and I were actually working on a program with trying to do buprenorphine detox, the question became, who was the eligible provider? So the BHO said it has to be a psychiatrist. It can't be anybody else. We just went back and forth on this. We never solved the problem. I'm just trying to give you a level of some of the complexities, and you have to remember, because particularly in jurisdictions, in Baltimore, 65% of my arrests are opiate addicts. In a lot of these jurisdictions, this detox issue is the front and center issue in the jail, and the question becomes who pays for it. What agent do you use? Who pays for it? I have OTP requirements if it's a methadone program in the jail. A lot of jails don't want to meet the OTP requirements. There are lots
It's messy.
of issues on this mess.
Well, you just make it messier by trying to cram it into a health plan. So.
Now I want to go to the issue on physician supply. So I want to go back to the question, how many of the current workforce in the jail are part of provider networks? And as I said before, I think with a few exceptions, the answer is they're largely not. And I think I want to raise the question of what would it take on a going forward basis. And I want to start, Kathy, with what I heard you imply, and I want to mention two words, which is called board certified. Does everyone understand what I mean by those two words? Okay. Generally speaking, it is not currently a criterion in a jail to be board certified in terms of being part of the workforce. There are a few exceptions of that, Rikers being the major exception I can think of. Ed, can you think of another one other than Rikers?
Not sure.
Off the top, I cannot. Where there's been a criterion that the workforce has to be board certified. Contractors too, right. Rikers is the only one I know of that there's a board certified requirement in the Horizon agreement. Or was the PHS agreement. Other than that, jails as a general rule do not require board certification as a qualification for a physician workforce. Most managed care programs and many state agencies that are thinking about a managed care workforce, be that through PCCM or some other vehicle, do require board certification in order to do that. And just yesterday, I was talking to the gentleman who runs neighborhood health plans in Massachusetts and Rhode Island about this very conundrum, because that's largely a Medicaid plan. And he was talking about how they are still requiring board certifications for a minimum threshold for entry. So one of the questions I want to raise is, if we now think about the physician workforce, we think about the general shortage of practitioner supply that everybody is predicting in 2014, and we can think of a lot of reasons, some of which we'll talk about tomorrow afternoon in CQA, in which the issue on board certification is not going to go away so quickly. We immediately hit a different conundrum that we hit in reference to behavioral. And I would like to hear from folks whether anyone has any suggestions for the management of that conundrum.
So let's say you've got in a large metropolitan jail, say Salt Lake County Jail, you've got 12 physicians that are employed by the jail. So if you did something similar to the way that you do it on the behavioral health side, if one of those persons was completely board certified and the others worked under them, then you wouldn't necessarily have to go fully board certified on the remaining 11.
How are your community plans going to feel about that?
Now, this is inside the jail.
Check with them. I would think they would be not 100% happy.
but this is for services inside the jail I'm talking about now.
But these services inside the jail under pending disposition, if I'm extending it to Medicaid, now become Medicaid covered services. That's what we're talking about.
Only if you're doing something that's got a billable CPT code.
I'm going to get there in a minute.
Which is not often.
Don't get ahead of me.
But I think but your point is that if it's through a plan, if it's through a plan, and if it's this way, and if it's that way, what will the plans think? And I think, I mean, Don has made point several times that may not be the way to go at all.
Okay. Well, that's
or if it is, maybe the provider that delivers the services that are billable is credentialed.
Well,
the
so,
others that are doing, the urgent care stuff that's
right,
not billable, and the health, the initial screening and all that kind of stuff, don't have to be board certified.
Well, but
So what kind of board certification are we talking about? There's a lot of
Family
boards out there.
either internal medicine or family practice for the primary care practitioner.
As recognized by the AMA group on specialty certifications.
Yeah.
That's kind of a closed group right now.
Right.
Okay, because there are other groups that provide certification for physicians who work in correction.
Correct, and I'm going to get I'm going to get there in a second.
Okay.
You're slightly ahead of me. I want to just back up a little bit to frame again why we're having this conversation. I heard Paul say that before he got his job back, Tom, when you had this job, that this desire to make sure we brought Medicaid payment into the jail for services that the jail is providing was the public policy goal of doing this. Is that what I heard you say, Paul?
There are three things.
Right. Yeah. That was one of them.
One of them is, yeah.
Right. And so the hypothesis that we're operating under, which we're challenging in the course of these discussions, is whether that hill, whether climbing that hill to have a Medicaid certified provider, have a CPT code, an ICD-9 code, meet utilization quality review standards, all the stuff we're going to be talking about today and tomorrow, whether that's a hill that was a great idea but may be a little too challenging for counties to climb. That's the 10,000-foot discussion I'm trying to facilitate. And it may be that jails make great loci for eligibility and enrollment, but not such great places to deliver Medicaid covered services in. So the conversation I'm trying to have is really that this has been a NACO goal for a long time, and as we think about it operationally, is it something that counties want, are able, think is appropriate, work with their contractors or whatever to try to meet that goal so I can generate an appropriate bill to Medicaid or a health plan for an individual who is pending disposition of charges? That's the 10,000-foot question I'm raising. Go ahead, Donna.
I wonder whether what type of data there are to paint a picture of, for people who are pending disposition, what kind of services outside of detox they actually get.
So let's have an answer question.
It may be a relatively small bucket of services compared to the services that people, the small number of people who are in the jail for a year and have diabetes and an amputation.
Right. So let me try and answer your question if I can. Okay. If you think about the definition of pending disposition of charges, which does not only include the pretrial, but also includes an individual who's been brought back on a technical, who's pending disposition of those charges. Generally speaking, the only people in a jail who are not pending disposition of charges are the sentenced. And to the extent that I have the sentence on appeal, I'm still pending disposition of charges. So, in fact, it is a very, very small percentage of folks in a jail who are not pending disposition of charges. Okay.
So are those people who are there for more than 14 days have a complete physical, correct? Generally speaking.
Under the NCCHC standards, that's
so correct. What percentage of people is that? How many?
So it's going to vary by jurisdiction. So in some jurisdictions in Chicago, last I checked I was 9 months for pretrial adjudication. Is that about how backed up we still are in the Chicago jail? Do you know?
No, I'm not sure, but yeah.
It's substantial.
That's reasonable.
Right. So your general, it's lots of people. So your general figure is that the folks who leave within the short period of time are those who bail out. The folks who are left are your poorer folks who, generally speaking, will be sentenced to time served at adjudication and will be dismissed. So if you think about the assembly line, those are the folks I'm talking about.
That might
Okay.
be somewhere around 40%.
Right, around 40% to half of the folks who do that. Those folks, generally speaking, have not seen a practitioner since their junior high school physical or last time they were in jail. They've beat their bodies up pretty bad. There's a reason they don't have the money to bail out, because they've alienated their families, probably through substance abuse, so that their families are not particularly interested in bailing them out. And they are the expense that counties incur. The psychotropic expense, the HIV expense, the Hep C expense. These are all significant expenses for which the original goal, I'm not putting words in Paul or Tom's mouth, but the original goal on pending disposition was to cost shift those costs onto the Medicaid dollar. Would that be fair to say, Paul?
Actually, it would be to restore the appropriate cost share.
Thank you. So
It doesn't seem like it would be that difficult, in that it seems that probably those folks that have HIV, behavioral health, serious mental illness, or other serious chronic diseases would already be, would readily be assigned to an internist or a board-certified family practitioner. So again, I don't know that you need to get everyone who provides health care.
that's an assumption that I have a board-certified family practitioner and internist on staff.
Well, right,
and I
I'm
think-
saying maybe you just need one instead of everybody.
So
Or you,
I mean, that's how it works in the homeless programs a lot, is
Right.
there's one person that's certified that works in a team environment, and the billing is funneled through that person.
Our West Texas Mental Health Authority covers 26 counties.
Right.
The doctor sits in Amarillo, and through telemedicine as a physician extender in the jail, usually a nurse, and it's Medicaid billable.
So Keith, I want to ask you a question. When you were a doc in Santa Rita, okay, the other docs you were working with, some were board certified and some were not, as I recall. Is that correct?
Yeah, that's true.
Right. And you, as a board certified internist who also holds a certificate in HIV medicine, I don't think you were being asked to see everybody in the chronic care clinic. I think you had non-board certified individuals that were also operating chronic care clinics. Would that be fair to say?
Yep.
Right. And so I think the challenge, and we're talking Oakland, California, and I was about to go there. I'm talking Oakland, California. I think that's relatively common. So I think it would be naive to believe that in a correctional setting, that the only practitioners who are seeing those individuals with chronic disease are in fact board certified. I don't think that is reflective of the delivery system in jails. Flo?
I'm going to get right up to the edge of what I know, and I'll be probably talking about something I don't exactly know, but we are stopping all incident to billing in North Carolina, where people can, other licensed practitioners can bill through the physician. And we're doing that because of the new fraud and abuse rules, where the person billing has to be absolutely the accountable person. So a lot of things, like we can't use provisional licensees anymore. And so,
but Medicaid could allow that in a jail if it wanted to. Medicaid can do anything it wants to. I mean, not anything, but there's a lot of flexibility, though.
And I think, again, part of what I'm trying to, we're not looking for answers. I'm trying to facilitate this discussion to give Maeghan and Paul guidance. I mean, there's an agenda here, and that's not so covert, which is to give Maeghan and Paul guidance on how steep this hill is in terms of their membership education and their advocacy. I think it's very clear that in most jails, even in the chronic care clinics, I have non-board certified personnel that are providing those services. I think that is the rule rather than the exception to the rule, okay? I think that if we think about this clearly, I think there are the incident 2 issues that Flo just raised. There are the issues that of plans or managed care entities or PCCM programs or someone else being slightly uncomfortable with having a provider be the billing entity for a patient that they did not personally see. I don't think it's realistic in the assembly line of a jail for Dr. Barton to walk into the exam room of all of the non-board certified physicians in that jail and say, hi, how you doing to the patient, so he has a face-to-face. I don't think that's a realistic assembly line. And so I think the challenge I'm trying to articulate on this physician issue, and where till I get to advanced practice nurses in a few minutes, I think the challenge I'm trying to articulate is this something that is realistic to expect jails to be able to recruit and retain a board-certified workforce for whom plans that are subject to report cards, that's tomorrow afternoon, okay? But it's there, I can't diminish it.
It's good, I didn't realize it was there.
It's there, it's there. Can in fact engage in effectively billing Medicaid for those individuals who are pending disposition. And if the answer is no, that's not realistic, then I think Paul and Maeghan need to rethink help their membership rethink, is that a more accurate way to phrase that? Yeah. To help their membership rethink where their membership has been coming from, flow.
Well, there's a break-even point in all these kinds of billing where you have to have enough billable hours to afford the staff
Back
and
of
the
the house.
infrastructure to do it.
Right.
And 20 years ago it was $100,000. It's probably 10 times that now.
Right.
So our large jails, like Charlotte or Wake County, they could do this if they really wanted
But
to.
only if they can attract a board-certified workforce.
Right, and they probably could in
Only
the
if they-
area.
Only if they can only bill a board certified.
Only if they can only
workforce.
bill, right, only if they can only bill.
But most of our jails, which
Completely
are
different.
small jails,
not.
could not ever make enough money to make it
Correct.
worth
Well,
the
part of why I'm
infrastructure
using
costs.
Keith as my straw dog is having worked in the jail in Oakland, California, which is a fairly large city with a relatively large jail, and understanding the challenge of that jail in recruiting board-certified personnel, I don't think is atypical. And I don't think, Dr. Barton, you would necessarily be comfortable submitting bills on behalf of your fellow physicians you were working with in that jail without your having a greater supervision of their work. Do you think that's fair to say?
Yes.
Right? And so I think that what I'm trying to articulate is this is quite a conundrum that we face, and state Medicaid, well, I don't disagree with you, Donna, state Medicaid agencies can do anything they want. I don't think there's a lot of political constituency for the population that's in jail. I think that we've done with Center for Healthcare Services Strategies with Steve Summers and Allison Hamblin, we've done a lot of small working groups to try to bring this David Mancuso data on cost savings and everything else to state Medicaid agencies. I think we're moving up that hill, but I think it's a very steep hill. Yeah, Ed and then Pat.
Well, I was going to add that from the perspective of most jails, they are not in the business. The reason that they exist is not to provide health services. They've got lots of priorities. The sheriffs, and the majority of counties have elected sheriffs that run a jail, are elected for other reasons than the efficiency to which they can provide health care to those who've been arrested. And we need to expand the discussion towards how to effectively work with the complications of federal agencies and state agencies and these guidelines to, well, perhaps a role that NACO and county administrators can play is thinking of a new design for the development of health services to those who are incarcerated, rather than expecting it to be through the sheriff's office directly or the sheriff's office without some coordination. Most jails, whether they're run by the sheriff or an administrator, are going to do a screening on a person when they come in the door and try to determine if there's anything serious that needs to be addressed. Those that are accredited will go beyond it and provide for a health assessment. The greatest liability is with those patients with chronic disease who go undiagnosed, untreated, underdiagnosed, and undertreated. That's the biggest risk for a bad outcome. But the bulk of the activity, the reason that the staffs are as large as they are, is just because of the quantity of people that need to be seen in order to have an assessment. The whole opportunity for, in 2014, for the possibility that someone would come into the jail with a health record already established because they're in an insurance program, an exchange, or something else, and then coordinating that exchange of information has the potential of saving the counties a whole lot. Because right now, when someone comes into the jail and they say, I am an asthmatic and I need this inhaler, the health staff at the jail need to make a determination if that is true and go through their own assessment process in order to continue the medication and the treatment that they're on. So it's complicated, and I hate to add to the complications that you're already describing here, but to get the enthusiasm and participation of jails and their health staff, which it's a challenge under the best of circumstances, and to complicate it with, now we want you to be involved with more paperwork and guidelines and things.
I hear you saying several things I want to respond to. So one, I just want to inform folks that on April 3rd, COCHS is doing an invitational-only conference on the role of HIT in jails. And actually, the Robert Wood Johnson Foundation is sponsoring a video, which we're doing in conjunction with Camden County, New Jersey, that describes the current process that goes on in Camden County when a mentally ill individual who's never been in the jail before is arrested for screaming at McDonald's, and how long it takes and how much work it takes to actually get that individual on appropriate medication versus if we had health information technology and it would take a half hour. So I very much appreciate.
By the way, Camden County is an exceptional.
Right.
Camden.
Camden. Camden, New Jersey.
Okay.
We're doing this in Camden, New Jersey, which is not exceptional at all.
Except there.
Right. And part of why we're doing this, Ed, is to exactly highlight the issue I'm hearing you say, which is in thinking forward to 2014, we have to seriously consider the role of health information technology and the opportunities it creates for jails. I'm also hearing you say something else, which I want to make overt and less implicit. Because what I heard you just say is maybe the square peg of Medicaid billing doesn't fit well into the round hole of the jail system. And maybe these are not consonant processes. And I think that's, again, important. If that is what people are thinking and experiencing, then I think that's important information for Paul and Maeghan to think through, because that's part of what COCHS' goal. I don't have a horse in this race. I'm trying to facilitate a conversation to elicit these issues on the table. And Pat, I'll let you go ahead and give me more.
You know, if I were Maeghan and Paul, and I was going to talk to my elected officials from around the country, you have two groups there. You have the sheriff, and you have the folks that actually appropriate the dollars and raise the taxes. The sheriff may not care if he's got plenty of county general fund to provide the medical services. He might not care about the heat that the elected county commissioners have to take to raise taxes, but they care. So what's going to happen there is there's going to be some pressure at the county level, and when you go in and say, look, in 2014, all the medical services, for the most part, that we were paying for with county general fund are now going to be able to be paid for with Medicaid. And guess what? For the first 3 years, 100%. The county elected officials, that's the constituency right there. They're going to go for this. Then I would say this. Now, if perfect world, so all of a sudden, right now in Utah, we have 4 accountable care organization plans. That's our new way of managing the Medicaid population. We got a significant part of their membership inside the Salt Lake County Jail. we go to them and we say, look, we're going to give you access to our behavioral health plan because we're carved out, which they want. In return for that, we want you to subcapitate us at the county level. And you give us a reduced cost per day, and we'll eat the rest of it because we're still saving money, right? So we get in there, and all of a sudden, what happens with that? Then all of a sudden, all the standards that may have to be in place, we can start to negotiate on those. What are those going to be? Maybe we have one board-certified person, and everybody else under them is under their supervision. And we're allowed to build that to the health plan. As soon as the health plan's okay with that, and they do the utilization review and they see it's okay, the state Medicaid office is going to be fine with that. So I think there's a whole variety of ways. Because remember, under this healthcare reform stuff, it's all about different reimbursement systems. It's about expansion of workforce. It's all those things. So I think it's going to be a climate that's going to allow us to work a lot of deals out that we haven't been able to do in the past.
So what I heard you just say was, yes, there's lots of opportunity for innovation, and that's an example of an opportunity for innovation. And I think
don't leave money in Washington.
right,
I mean,
right, and I would
starts with that discussion.
I
Don't
would
leave-
totally agree with that. I think I'm back, however, to where I started this conversation, which is even in the subcapitation arrangement, advancing ahead tomorrow afternoon, even in the subcapitation arrangement, that plan's report cards are partially based on the board certification issues
I don't
of.
think you can assume that.
Why?
Go ahead.
Maybe this population is not in the report card.
That's right.
I think that would be something you would want to, one would want to consider about whether it would be part of the report card. I also think that while I think some Medicaid directors might be very happy with it, others might not.
Right.
And where would CMS be on this? CMS also wants to make sure that the Medicaid program is providing high quality care. And if there's going to be a concern and a suggestion that paying for health services in jails is going to result in substandard care,
It's going to go nowhere.
It's going to go nowhere.
That's the wrong argument.
No, I'm not saying.
Yeah.
Okay, go ahead.
Yeah, just a couple things. One was we get a lot of money from the county and the city and the hospital district. And the State Department of Health Services, which is over our Mental Health Authority and Substance Use Authority, actually came and used our data and got $82 million from the Texas legislature for what they call crisis redesign to create these crisis diversion programs like in Bexar County. We talked about saving taxpayers money and improving the public safety net. When we make public presentations in front of elected officials, it's all about improving the public safety net, and then treatment is the backdrop for that. Now, Malcolm Gladwell wrote that article, $1 Million Murray. These folks that end up in jail who get when they die a lot earlier, but when they do die, they're $1 million patients, and guess who pays for that?
Right.
Now, if you really want to drive down the cost of health care, you've got to deliver services to these folks, and doing some health education, health engagement in the jail, and whatever you can do is going to really help. Then maybe doing more of the active treatment on an outpatient basis and doing linkages, but just to say, hey, the jail's not going to work, we can't accept that because these people need treatment, and their treatment is resistant. And
I hear that, but Kathy, I heard you say a magic word, which was substandard care. And what I want to argue is, for good or bad, we've defined board certification versus non-board certified as this distinction between standard versus substandard care. And at this point in our paradigm, I'm not putting a valence on it for good or bad, I'm just acknowledging that at this point in our paradigm, we consider non-board certified personnel to be substandard, okay? Not good or bad, right? Now, Ed briefly mentioned on a potential workaround, which are certain certification programs which are specific to jail docs. And Ed, could you talk a little bit about how those work? Because I don't think most folks understand what that is about.
So there are a lot of professional associations out there that have thought about developing certification programs. And historically, a relatively small subset have been recognized by a body, I forget its name, but it's sort of authorized by the American Medical Association, and these are recognized specialties. It's not very many, perhaps a dozen or so. The last one that was added, I believe, was emergency physicians, and that's been at least 10 years ago or so. And other groups have applied, and as I understand it, this body has been reluctant or hesitant to expand the role of certified specialties. Some groups have gone ahead, and ours is one, with developing a certification program for correctional docs, dealing with and we see correctional medicine as a specialty because of the way you have to deal with the barriers, the public health aspect of the clientele and the opportunity, and for a variety of other reasons. It does take special training. Certainly one of the biggest problems in our field is staff turnover. People come in for a while, and then they're gone. Someone else has to come in, and they lose perhaps the ability to be a good patient advocate when they're in the job for only a short time, or what they found in the job they're expecting. So we have a certification program. It may formally apply for recognition through this other group, but it may continue for a long time without that type of
And there's an implicit tension there because you have things like the University of Massachusetts that are now developing a fellowship year post-board certification in correctional medicine. So you have some implicit tension that's out there in the field. I think the question that
tension? I don't say there's tension. I think that's good. I think there's a number or some other...
Competitive. Remember, there's competitive forces at work is probably how I would phrase it. For what it means to certify a correctional doc is how I would define it.
Okay, I don't see it that way. But
right. And I think the question I'm raising, and Ed, why I asked you to contribute that, is I think it then raises another policy question, which is, can I change my definition, Kathy, of standard versus substandard, and can I use a certification of the type of program Ed is talking about as a proxy measure? Now, Ed, how many docs do you have certified under this program currently?
Well, the first exam has not yet been given.
Right.
So this is just in development.
Right. So one option would be to think about that exam and that process as an alternative route for assuring that we're not providing substandard care. That would take a burden off, but it would also require an educational process of plans and state Medicaid agencies to recognize this as a mechanism of assuring a quality care delivery system on the personnel within the jail. Donna, and then I want to go to advanced practice nurses.
Well, this probably applies to both anyways, but I'm thinking that this is about the assumption that a report card could get screwed up if you were to take on another population, and why I don't think that necessarily holds water. So we're working on with a number of states that have grants, CMS demonstrations to combine the dually eligible Medicare, Medicaid. They're gigantic, complicated things. And it's likely that in the duals demonstrations, the organizations that would be credentialed to take risk from both and money from both parties and take care of a person who's dually eligible and do everything for them are going to be Medicaid health plans quite often. Some of them will be SNPs, the Medicare Advantage plans that are special needs plans. So at the point of development that we're at now, the discussion is how do you measure the quality of those delivery systems? And what we know immediately is that you have to separate them. There has to be a different measure for that population because it's a different population. So it's not an assumption that the plan is held to a single report card for all of the people that it takes care of, when there are different programs that it's administering. So there'd be maybe a report card for the Medicaid population, a report card for the duals, because they're really different. And if you're doing prisons or jails, there's a different report card for that. So
I really appreciate that, and I want to share why I really appreciate that. What I keep saying is, if we want to bend the cost curve, and we really want to bend the cost curve, we have two populations that we can do that with: the duals and the folks who are in and out of the criminal justice system.
Yep.
And the rest of it, we're just chipping away at the iceberg.
Well, they're not that expensive.
Right, we're chipping away at the iceberg.
So, but to your point about credentialing, perhaps there's a different model that applies to correction systems because fundamentally they are different places. So I wouldn't assume even that board certification is a hurdle or a marker that's essentially across the board.
Right, so
maybe it doesn't work.
I think that's great. Again, I think at a macro level, these are the two populations we want to target, are duals and criminally involved people in terms of cost curve. I think the challenge is you have a Bob Masters who's sort of the champion of the duals in terms of thinking through this and thinking through how all this plays out. One of the challenges with this criminal justice involved population is politicians generally want to run from it rather than champion it. And we don't particularly have a champion like Melanie, like Bob, who we can turn to help think through with the appropriate actors, of which there are many, on what might a different form of assuring I'm not providing substandard care look like. So I very much appreciate that. I want to go back to the comment I made about behavioral, which is for any of this to happen within a political arena, I am in the offices of the National Association of Counties, that within a political arena, we have to figure out where there are champions who would be willing to advocate for this cause and for the need and appropriateness of this cause. So, Donna, I agree with that. What I don't see on the horizon is where those champions exist and who would do it and why. That's what I don't see on the horizon. Go ahead, Megan.
I would disagree. I mean, I think that the comments about getting politicians on board, particularly from the county level, that's why we're doing this.
That's easy.
This isn't Paul and Anita
right.
and the three of us here at NACO and Dalen included. There's really four of us working on this. This isn't we're doing this at the behest of what our membership has asked us to do over the years, and taking on some of that. So I think that hurdle I think is fine, and I think Pat Fleming outlined that well. You're going to get that. If you look at, let's say, the 100 largest counties in the country, these are the people we're really talking about who will make these changes. I mean, you're not going to get all 3,068 to do this, even if we figure this out and can answer all of these questions. So when you're looking at that, we have champions within those larger counties that will take that on and have.
My question isn't whether you have the champion within the counties. My question is, do you have the champions within the federal bureaucracy that's got to build? Right, that's the challenge I'm raising.
Is there any, or at the state level?
Yeah. The champions in the health system that you're trying to work with. So, for example, so you just need someone within the MCO to see what the revenue is for them, or within. So you just need it within the partner. Medicaid doesn't necessarily, because like Donna was saying, it's really flexible. It doesn't necessarily have to change as much as what health reform's focused on is the service delivery mechanism that really needs to change and how it interfaces with Medicaid.
The only thing I would add to that is, and I don't want to contradict myself too much, but it has been a challenge for CMS to recognize counties as a player in this. So in any of this over the years, so they don't really recognize counties as a payer, which they are. I know it's through state, but so that still brings that piece up. I still think that is quite a hurdle to get through. But
go ahead.
I think it's a tremendous hurdle too. I mean, I think even if you had champions in CMS, they're so busy at this point doing everything else. I think this is hard to get through, and
Wouldn't this just be a state plan amendment that they just rubber stamp?
But they don't rubber stamp state plan.
Well, in the future, though, they're talking about making it a lot easier.
They're starting to rubber stamp more things, actually.
But is it a state plan amendment?
Well, that's,
Well, I
some
don't-
of it is,
it could be.
some of it is,
Doesn't
some of it
that-
isn't. When you get into the report cards, no, it's not a state plan amendment. I gotta deal with NCQA on that, I'll get you Flo.
Yeah.
I mean, there's,
I think there are whole issues, I think there would be, I think at least initially there would be issues about the delivery system. I think, and on the congressional standpoint, if you were looking for someone, I think you'd end up having a combination of three things like, people in the criminal justice system, I'm not sure I wanna go there. And then you'd have the
You're already
issue of and then I think.
bums on drugs, bums on
Bu-
drugs.
Bums on drugs. And then the other thing is that suddenly, if I really start making all of this, getting all these people Medicaid covered, that's gonna cost more money, and the CBO is may end up scoring it as an expense, which is
That's why
kind
we
of.
don't do this. That's why we weren't successful legislatively.
Right.
And it's why we really, our best shot at making progress is gonna be,
I think it's administrative.
Expansion population
Yes,
is the
that's
people that
correct.
you guys are
Right.
talking about.
Not disagreeing,
Yeah.
not
Yeah.
disagreeing, I'm just
Yeah, I know,
trying to,
it's still
sort of
hard.
balance and.
So I have another possible person that could be added to the mix here, or a group, and that would be the FQHCs that are serving, that are providers already.
We've been inviting them, and I think also Allison Hamblin is gonna be joining us tomorrow from Center for Healthcare Strategies. So
Because-
we've been trying to bring all those folks into that. I think that.
Because they already bill Medicaid, and they
yeah,
already
they're-
take care of inmates, so.
They generally speaking, don't particularly see this as their population, women and kids as their target population. And so I think part of what I'm
Mm-hmm.
hearing in this conversation are the frustrations and Flo, I'll get to you in a second, I appreciate your patience. Is the complexity of this. I think that the questions that we're trying to drill down in the next day and a half, I think the eligibility enrollment piece was easy. Jail is locus of eligibility enrollment, everybody's for that. I think when we start getting into these questions on providers, tomorrow on billing and medical records, on QAUR, I think we start hitting more substantive obstacles that aren't so easy to figure out workarounds. Flo? I promise, Flo, I'll get to you next. Yeah. Go ahead.
One of the reasons I hope that we find a couple of jurisdictions to try this, because I agree with everything you're saying, it is a complete uphill kind of thing. I worked for 3 years with a Robert Wood Johnson grant, with John O'Brien,
Right.
with our juvenile justice system, because it seems so easy to get kids eligible for Medicaid in the juvenile justice system. But at the end of 3 years, their secretary said, I don't want to do this because this is going to change. It's going to change to meet these requirements on the Medicaid side. I'm going to have to change so many things that I can't do it. I'm not going to do it. I don't want to do it. I'll figure out some other way to do it. The pressure, however, is that if this is the way that Congress has decided that all these people are going to be covered, then the pressure on us in states and counties is going to be huge.
Right, and I think the question that I'm trying to raise is exactly at the jail level. Is this so complicated, okay,
It's complicated.
that it's really not a fight that's worth fighting for? That's the question we're phrasing. I'm not asking yes or no. I'm just trying to frame the question, and the purpose of these small working groups is to delineate the issues and the shape of the hill that would have to climb so that Paul and Maeghan can communicate to their constituency, not just their elected, but also the operational folks, the National Sheriff's Association folks, on what the shape of that hill looks like so people can go into it with open eyes. Yeah,
But
Kathy.
put a price tag on it, though.
Right, Kathy.
I mean, I'll comment about what you said here, and then I want to. I mean, I think in the long run we have to address this, because if people are going to end up being incarcerated, pending disposition for periods of time, and they otherwise have to have insurance, starting in 2014, you're going to have serious continuity of care issues, and we have to find a way to do that. Otherwise, all the good work on either side of an incarceration
Falls
is
apart.
going to fall apart.
Just like it does right now.
Just like it does right now, except maybe
Worse.
Except worse, because
Right.
now we are gonna be paying for it like we're not paying for it now.
Right.
So I would say that's one thing, and then the other thing I was also thinking about in terms of advocates that and places you might go, and with so much of the jail population having substance abuse, mental health, and probably developmental disability issues, can you also, can we go to those kinds of people and see if they will join with them? I mean, there's probably a lot of push and pull between the jails and those healthcare systems.
Well,
But there,
Becky
but
Vaughn
it's
from
a-
SAS was here this morning, so we're,
You know,
What do you mean when you say those kinds of people? Like, what types of organizations?
They're the advocates. When you think about the mental health agencies,
Like
when you
the-
think about the developmental disabilities agencies,
Mental health
so
liaison
many of their clientele ends up in jail for longer and short periods of time, disrupting whatever care they've been able to, whatever care the advocacy side of it has been able to provide. And there's so much concern about it, and there's a lot more work being done at that level, and maybe there's a way to get them also to work with, have SAMHSA coming through and working with CMS along, because there really is there's no correctional group at the national level, no CMS type, SAMHSA type agency, right, at the national level,
none.
because jails are local issues.
Right, you got it. That's why we're here in the NACO building. Yeah. So if we could, I want to move off of this issue of physicians for a second and make our lives more complicated and talk about advanced practice nurses. So Ed, can you talk a little bit about, have you guys thought at NCCHC about a similar credentialing program for advanced practice nurses? Has that been on your radar?
Well, we actually started with nursing. The threshold that we used was RN, and we currently have, I think, maybe 3,000 RN, I'm sorry, we have 3,000 people certified in general correctional health care. We started advanced certification at the RN level, and have a small group that's currently certified there. Bringing up the advanced certification, the advanced nursing is intriguing, but I'm not sure how many of those exist in jail healthcare.
Nurse practitioners, physicians, assistants do the bulk of the work in most large jails.
Most large jails.
Most large jails.
But there's not that many. I mean, there's a couple, depending on how you want.
Right, well, if I go back to Megan's statement that we're talking about the jails in the largest 100 jurisdictions, okay?
Okay.
I would say that most of those jails in the largest 100 jurisdictions are heavily dependent on nurse practitioners and physicians' assistants for the day-to-day provision of care.
Agreed.
Right. And so I think one of the credentialing challenges I just want to pose, going back to some of the work that you guys have been doing on docs, is to try to plant a seed as part of what we're doing here, to consider whether there might not be a way for you guys to certify what's in effect a correctional specialist, PA or NP, within the NCCHC efforts that you're undertaking, if you hear where I'm going with this question, as a way, as a workaround, in effect, because that's really what we've been talking about, that if our hypothesis is that I'm not suddenly going to recruit more board-certified internal medicine and family prac docs to the county jails, that's not a very likely thing that I'll be able to do. I'll do some, but I'm probably not going to do enough to meet the need. Then your certification becomes a proxy measure. I think the question I'm asking is there a similar proxy measure we should consider in reference to advanced practice nurses? And then the question becomes, what's going to be relationship between plans, I'm turning to you here, Kathy, certifying advanced practice nurses and PAs who are supervised by a non-board certified physician? Do you understand my question?
I do, and I don't know the answer, but I think plans, many of them come from, FQHC kind of a world where, nurse practitioners, advanced practice nurses, these are very standard delivery modes of care.
Most of whom are certified by board, supervised by board certified practitioners. So the hook and that I'm raising here, you understand?
Yeah, I do understand the hook.
It's the same as the other issue. If it's a different model of care and a different population, then maybe the rules are different. So.
Maybe one of the other, maybe there's another way to get more telecommunication kinds of issues at if you can't get them in a different group. But I agree, maybe there's a different way to.
Well, that's really, I hadn't thought about that. Going back to your prison model, I'm doing a lot of that telehealth within the prison model. I generally haven't been doing it within a jail model. That's an interesting thing that you just raised. I have a lot of cross-state supervision issues I haven't quite ironed out yet with that. But that creates some really interesting questions about the relative role of advanced practice nurses and PAs who are distally certified by board-certified physicians. I mean, that's an... Right. Right. That's a really interesting, I appreciate that a lot. That's a really interesting thing that we hadn't thought through as a possibility.
At some point I would hope, and it's probably going to happen, but that we kind of focus on outcomes. And I'll give you a very simple example. We opened a sobering unit. So these people are folks that are chronic inebriates and used to get arrested, most of them 3 or 4 times a day, and they'd put them in the drunk tank. They go before magistration, and they let them out before they sobered up because they didn't want them going to DTs and dying and having the health care cost. So they were always impaired. They never got to the point where they make a good decision for themselves. So we opened this sobering unit up. We hired RNs. Well, these people come in, they're throwing up, they're defecating on themselves, they look terrible, they smell terrible, they're acting out. One of the first RNs we hired got clocked, knocked on her butt, the first time we hired her. And they didn't treat these people with dignity and respect. They didn't, there was no, bonding of any kind. So we had a real hard time getting people to detox. We hired EMTs. People are used to going to nasty wrecks and handling, and they turned out to be the berries. I tell you, they are fantastic. We have a bunch of people in recovery. We have phenomenal outcomes, So this little place that where people are drunk all the time. Then we have a homeless campus where we have an in-house recovery program that's alcohol and drug free. I'll put our outcomes up against Betty Ford, with some of the very sickest people in the world, and it didn't cost very much money. But do we do it with a bunch of expensive, board-certified people? The answer is no, we don't.
Right. So Leon, you just took me to the next question I want to briefly introduce today that we're not going to have time to discover in greatness. And Nan, if you could flip me over to the next question, which is this relationship on scope of service and what type of personnel I use versus what type and how I manage that. And the conversation that Dr. Barton and I have had over and over again in our office, to give you a simple example of this, is how standing orders, which are incredibly prevalent within a jail environment, how standing orders within a jail environment differ than standing orders within a Medicaid environment. So typically a standing order in a jail environment gives the nursing staff tremendous latitude on using their judgment on who might need a given medication, as opposed to delineating, you have a standing order to give Mary, John, Philip, Pete, and Joe a given medication. In a jail setting, you have a standing order to give the medication to anyone that you may deem necessary.
Prescription medication?
Both, yeah. And so there's a scope of service issue, if you all hear where I'm going with this, that I think about scope of service differently within a jail setting than I do within a traditional Medicaid setting. And typically when Dr. Barton is in the jail and the nursing staff ask him to write a standing order, he's not seeing everyone in the housing unit that he's writing a prescription for a standing order in. He's leaving that, is that not correct, Keith, to the nursing staff to determine how to dispense that medication? Would you say that was accurate? Yeah.
Well, I think I never write those orders. I assume that they are written by the medical director.
Right. And that they're not based on an individual patient is the point I'm trying to make.
Well, they're definitely not based on an individual patient.
Right, that's the point I'm trying to make, that they're not based on an individual patient. That's a very different scope of service in terms of the role of the nurse than we think about within a more traditional setting. I think Leon's point that he just made on EMTs is another issue in terms of scope of service. Ed, you and I both know that I have jurisdictions that have that assessment done not by a nurse but by an EMT when people first come in. And that's considered a perfectly appropriate role within a jail setting, although whether the Board of Nursing knows about it or understands it might be a separate issue. So
sometimes even a corrections officer.
Right, sometimes even a corrections officer, right, who we've hopefully given some training to in order to enable them to do that assessment. So the question I'm wanting to raise and what I would like to concentrate talking about in our next meeting is, if we're going to talk about provider usage and provider workforce within a jail context, then the other thing we need to think about is what is the scope of service that we currently have jail personnel doing, and how does it jive within the Medicaid paradigm, or to use Kathy's word, would it be considered substandard?
Or does it matter if you're not going to bill it?
Huh?
Or does it matter if you're not going to bill it?
Well, yeah, go ahead. Is there...
Well, what we've been doing in the homeless community is doing what we've been calling Medicaid crosswalks. Yep. To crosswalk what is typical in a supportive housing program, for our example, and what Medicaid is providing, and we define the population. And in some states, we compare it to, if they're not doing anything with Medicaid and supportive housing, then we compare the services in supportive housing to other, like, home and community-based services that they're providing to other populations, to try to show Medicaid that they're already doing some of these services already, and to show us what is typically not a Medicaid-funded service. And so in that, we've been able to engage, that's allowed us to engage in a conversation with state Medicaid from a cost perspective and from a, just that leap of, should Medicaid maybe think about Medicaid or even managed care, because in Massachusetts, it's been a managed care conversation. Yeah, and then what mechanism they're going to use to fund the gaps in services. That's where we are in a few states now.
And
if they're going to package it and bring more services to the table.
Right, and Peggy COCHS has been very involved with Richard and Andy, as you may know, in the development of that crosswalk. I think the challenge within a jail setting is it's so different from what would be considered, sorry Kathy, a standard practice delivery system, that developing that crosswalk is extraordinarily challenging. That this concept of a correctional officer assessing a Medicaid patient as to whether or not they need to be seen by a practitioner might be something that a Medicaid agency might have some challenges with.
Not if you don't bill it.
We run into the same things, though, when it comes to case management.
Right, but that's different because you have an established person who you guys know, and the question is, who is their case manager? This is a question that I have someone who's been arrested, who belongs to, for the sake of argument, United Health Plan, who's a health plan member, who has been arrested, and I now have a CO making a decision whether or not that person needs to see their practitioner, and I happen to know that this person is a diabetic, and this person is drunk and stoned and not going to communicate very well with the CO, who they're hostile to.
And the CO is being driven by a 10-question questionnaire.
Right. And that's how the system works right now? Okay, just so you all understand.
I guess our crosswalk isn't about like the intake. It's about trying to get Medicaid to fund, looking at
what services,
practice,
what services
the scope
are fundable.
Of services and what services are fundable.
Right.
It's not about the intake or where or any of that.
Right. The distinction I'm making, and let me be clear about it, is that within a jail, I have, going back to what Mike was saying about the 10-question assessment, I have some very unique ways of doing business to process people quickly and hopefully effectively that within a Medicaid managed care context might not be seen as appropriate. In other words, if you think about the 10 questions the correctional officer asks, they may not effectively be able to assess or determine whether this patient has various risk factors that would warrant them being need to be seen by a practitioner.
But just to clarify the terminology here and the scope, it is true that in some jails, a corrections officer might have a list of perhaps as few as 10 questions. I don't know that.
Right.
But earlier, you were clear to talk about the large jails. That does not happen in the large jails to the extent it happens in small jails. In the large jails, and we're talking about, by the way, a screening process rather than an assessment process.
They may not have an opinion on.
The
You
plans
wouldn't
might.
bill for that. Yeah.
Yeah, a screening is just a step that one takes to see if there's any urgent needs that have to be addressed and if a referral is going to take place. So it's, for the sake of the description on the record and the videotape, I didn't want to give the impression that it's common in larger jails for a corrections officer who is not particularly well trained to do a 10-question screening process. In fact, in Rikers Island and Cook County and San Francisco and these other places, the screening is much more advanced and is done by a health professional.
Correct. So let me, before we do that, Don, let me ask what I would like to do next time, just to be clear. I think what would be helpful next time, and I think, Mike, if I could ask you and Ed and Keith to have an offline, I think what would be helpful is if the three of you could describe what a typical assembly line looks like within a large jail for folks who may not know or understand that, in terms of how that relates to scope of service, if you all understand the request I'm making. What type of person is likely to take on what function? Mike and Keith and Ed, you guys understand the question I'm asking? Because I think that'll hit up on my question of who does what, who provides the chronic care treatment, what's the role of the standing orders, all these kinds of scope of service questions. So if you guys could sort of start us off with that, I think I'd like to have a conversation about how that works. I think the question, Donna, I want to put our eyes on there is that, going back to Pat's comment on subcapitation, that if I'm not looking to bill transactionally, for example, but I'm looking to basically create, let me call it a new provider type, for which I provide some sort of subcap or global payment, I think the question I'm asking is, does the assembly line and scope of service that's being delivered by this provider type that we're hypothesizing might exist, is that perceived as being standard or substandard, to use Kathy's terms? And what would I need to tickle, if anything, to make sure that it was perceived as standard? Do you understand the question I'm framing?
Yeah, but I think I would suggest that Medicaid may not have a standing to render an opinion on that.
Correct, but plans
Perhaps
might.
the plans do what Medicaid tells them to do. But the bigger context is that if we're looking at a billing services that are currently approved by Medicaid that have standards associated with them, that's fine. It excludes a lot of the other things that go on in jails because they're not of interest to the Medicaid agency. It's like Medicaid agencies don't evaluate the process by which someone arrives for a physical at a school health clinic.
No, but they do evaluate
They just
the
pay
process.
for the school health clinic visit.
They do evaluate the process through which JACO certifies a hospital and ED certifies jails through the NCCHC program. And so the question I'm wanting to put on the table, because I've heard us imply that perhaps we might have one of the ways around this issue on board certification is we might have other mechanisms of trying to document that I wasn't providing substandard care. Okay? And so the question I'm trying to elicit is if I might have other mechanisms to determine that I wasn't providing substandard care because I may not be able to meet the threshold of definition that you set for us, Kathy. Then my question becomes, if I look at the assembly line that's typical in a jail, and I look at that from the perspective of a plan or a state Medicaid agency, do I perceive it to meet a normative care standard? That's the question I'm trying to put on the table. And that's where I'm trying to say maybe that's a workaround on provider workforce. In other words, another way to frame that is maybe it is processes rather than who's delivering X service.
Suppose, yeah, that I can see that.
Right, that's the hypothesis I'm trying to advance.
Another thing I want to mention is that a way to answer these questions might be, it's too late right now for the first round of the innovation grants because they're all due next week, but this would make it dandy.
There are folks who are putting in innovation grants exactly around these issues that COCHS is familiar with, okay? So I know that there are some CMMI applications that are going in to explore these very questions, okay? So that's already been on the table, and there will be applicants. We'll see whether they get funded or not.
And if not, maybe, we bring them together and package it more strongly for the next round, because supposedly there might be another round.
Right, but I'm just letting you know that that's out there. But I do want to say for the next meeting, because I guess part of what I'm trying to facilitate is that I heard there being discussion again on maybe we think about this within a different frame, within a process frame rather than the typical standards frame. And in order to determine that, I want to make sure that everyone understands the processes that go on in the average large jail, because I think that most people do not know or understand those who are sitting around this table.
Well, I would just say that I think that the way I think that the service way, the way to, instead of the provider or the process, another way to think about it is the service components that the folks that are staying in jail are receiving, and thinking about it from that perspective. Might be a more direct line to, because the processes, it seems like too much of a leap, because Medicaid's not going to pay for those things anyway, and they're not going to get that, and they're not going to.
Well, I hear that, and I think where you're hearing me be hung up is I'm hung up on the workforce question, because I don't believe I'm going to get board certified providers.
Well, we're saying you might not need them.
So you think that ED certification will stand in lieu?
No, not even.
Yeah, well, because the way that the system is changing, and to be more flexible, to reduce costs, being able to be focused on the triple aim, it's really allowing for more flexibility within the system as to what the providers look like, what the makeup of the providers, where they're providing care. All of those things are up for conversation.
I'm all for it. So if you'll bear with me, we'll try my exercise at our next meeting, and if we discover that we hit a blank wall, I'm happy to go back, Peggy, to the route that you're suggesting, okay? I think educationally, from where I sit, I do want folks to understand the process that goes on in a large jail in terms of who provides what service, when, and how. And I think that that's a really important piece for people to grasp as we consider these issues on workforce and scope. That's the point.
When we start talking about changing the level of workforce qualifications and all, we got to keep in mind that there is a constant group of outsiders out there that will begin to magnify the level at which they look at the quality of care that's being provided in jail. And so if we're reducing the provider qualifications, it's going to increase the outsiders' concerns about that quality issue even more.
Reduce qualifications, we're saying frame them.
Yeah.
Because they haven't been framed, and Medicaid has a rich history in recent years of waiving a lot of stuff to consider something completely new. And so what my takeaway from this afternoon's discussion is that we can look at this two ways. We know there's money on the table in Washington for the new population, and if we can get it to apply to the trial stuff, then
Pending dispositions.
we can get money for primary care services for people, a lot of the people that are in jail. So if we do that, then we can get our hands on that money one of two ways. We can bill the codes that are billable and make arrangements somehow to get them paid, which is going to limit, so that's one way. Another way would be to approach Medicaid state by state and develop another level of care for Medicaid services to be provided under.
So yesterday,
it could be a waiver, it could be a demonstration.
Right. So yesterday I spent the day in Rhode Island with Elena, working, who's the Medicaid director in Rhode Island, exactly trying to think through these issues in a very progressive state that has a unitary system. And it was a great meeting. What I would say is that this out-of-the-box type thinking that you are suggesting, Donna, is a little bit of a reach for where state Medicaid agencies are in terms of what they have on their plate.
I agree, but the fact is, 2014 law, a third of their new people are going to be these
No
guys.
doubt.
So.
But I'm just expressing that we've spent a long time working with Summers and Allison on this, and we're now working with specific states on it. And unfortunately, we're not having as much uptake as I might like because of the extent to which states are feeling overwhelmed with what they need to do between now and 2014. And so
it's not going to change regardless.
Tomorrow, but we hear that in February there's going to be a state-only version of the challenge grants that's going to come out.
I've heard that as well. I think the question will be, will this be something, given what states have on their plate, to what extent is this a population that they're going to put a high priority on trying to deal with? This is the issue I'm raising. Pat, one more question, then I'm sending us home.
Maybe Paul and Megan may know this, but what do we have a number on how many folks are inside of county jails around the United States? Do we know what the total N is roughly?
Yeah, well, it depends on if you use average daily population or not. But I mean, if you look at year.
We know on any given night, we know annually how many people.
Right, so 13 million.
Of which 10 million are unduplicated.
Right. 10 million
unduplicated. Unduplicated. So only 3, of that 13, only 3.
Those are the
bookings. Those are the
bookings.
bookings.
That's the BJS number on booking.
Yeah.
13 million?
Yes.
13 million bookings. BJS says there's 13 million bookings a year, 10 million unduplicated.
A year, but you asked a day.
Yeah.
No, a year. That was a year.
Okay.
A year. Okay, so that's kind of.
On any given night, there are approximately 700. On any given night, there are approximately 700,000 people behind bars.
So what I was going to say then is
jails.
Maybe the best way to approach this, because I understand the issue about the state Medicaid directors being completely overwhelmed and dealing with it. Why not approach it at a national level then? Your organization, NACO, Sheriff's Association, going to meet with CMS in Baltimore to say, could there be a Dear Medicaid directors letter that came out that clarified that there can be, you should be working to try to come up with healthcare systems for jail and prison inmates, and that maybe could be delivered at a different level or with a different set of people.
That wasn't
maybe
substandard.
That's the approach. Well, I won't say substandard. I didn't want to say that again.
Right.
But is that it's a different model. All we're looking at is a different model to deliver services. Maybe approach it that way so some direction does come down from CMS in Baltimore rather than trying to work it up through the states.
What do you think the likelihood of that is, Paul and Megan? Megan shaking her head no.
I mean, it's. I don't want to say anything is off the table. It's just, I think even the conversation that we had in August. I'm trying to be careful with my words, but. Well, I think it was better than what we anticipated and what we'd experienced before, but we're still not. It's still left kind of up in the atmosphere about where it will really fall, and so we've done I think what we can do around this, and I think it's worth thinking about, is this a place to go? But
and maybe you are being diplomatic, but I think one thing that some of our more progressive or forward-thinking counties ought to be engaging with your state Medicaid directors now. Don't wait for something to come from Baltimore. It seems like that would be a smart thing to do.
So one of my comments would be, I mean, I was the Medicaid director when one of the first letters came out, first state Medicaid directors letters came out that talked about the fact that you weren't supposed to terminate Medicaid eligibility. Well, no,
Yeah.
no, they said you're supposed to suspend.
Right, suspend.
Right, instead of terminate, which was, first off, news to virtually every Medicaid director under the sun. And second, none of the systems permitted you to do that. And the third thing was, I'll be perfectly frank, Medicaid director said, so I'm supposed to spend all my time worrying about people who are in jail, never mind getting the kids on Medicaid.
Right.
So,
Bumps on drugs.
yeah, bumps on drugs. I mean, anyway. You said that, not me. I'm just repeating it. So I'm thinking that perhaps rather than taking a full frontal approach on this, it ought to be more of a, states are now in the process of building new Medicaid eligibility systems with 90% funding. So those systems should make sure to include, stuff in there that recognizes the unique status that people who will get incarcerated could possibly be, and that it begin to sort of set the stage where states could at least, even if we can't go as far as we'd all want to go, that at least states have the tools to be able to address the issues and begin to address them that way.
And I want to just tell you that the challenge that you have here is one of where does the ball start. So we have been working very closely with New York State over the past month, which is initiating its health home program with 90% federal funding. And with assistance from Governor Cuomo's office, we're likely to add a metric to that includes reincarceration rate as a mechanism of success for the health home. That did not come out of the Medicaid community. It came from the criminal justice community that was concerned about appropriate alignment of incentives for the health home. I think I have a very forward-looking governor in New York. I think that his leadership is such, and his policy towards criminal justice is such, that for him this was a no-brainer to say, yes, this is an appropriate alignment of incentives in New York State. I'm not sure how many other states, had I had that same conversation, I would have had the same outcome in. So I'm exactly agreeing with you, but I'm also, again, wanting to go back to the political challenge of where are the champions for this population. And I think that this is something that we cannot simply get away from talking about. And with go ahead, Kathy, one more thing.
I guess I would also say, if you've got New York State to be interested in this, and it sounds
You're going right down my alley. Yes, once I get it in New York, guess where I'm going with it. Right.
And maybe Utah is interested or whatever, and
Right.
you're interested in getting NAMD involved.
Right.
I would suggest that you start talking to NAMD
Yeah.
about having this be a session in their in their late October meeting.
Right.
Because you won't get a ton of people showing
Right.
up, but it'll be
Right.
it's a new set of thoughts for
Right.
most of them.
Yeah. In my language, once I've gotten Greg to do it, then I can have Greg become my champion. And
Greg's
again,
busy.
Greg's busy like everyone else.
Very
Elaine is
busy.
busy. Everyone's busy. Right. That's the challenge. These state Medicaid directors are really, really busy right now. Okay. With that, I need to watch the clock. I need to say thank you all very much. For those of you coming tomorrow, we're doing billing and medical records in the morning and QAUR in the afternoon tomorrow. What fun. If you think this was fun, wait till we start drilling down into that stuff tomorrow. CPTs and ICD-9s, here we come in jail, right?
ICD-10s.
Right, ICD-10s. This group will reconvene on Thursday, February 23rd at 1 o'clock via the internets. And we'll be starting off with this presentation from Mike, Keith, and Ed, sort of walking us through the assembly line for scope of services in jails today. And with that, again, I want to thank you, Paul and Maeghan, and you, Paul, and your team. Where's Paul? Behind me. You, Paul, and your team. And thank you again for making it possible for us to do this via the web in February. Thanks again.